new emergent topic, cardio-renal metabolic syndrome. This is very interesting and important aspect. Basically, I have already discussed that we manage diabetes to prevent this syndrome only, cardio-renal metabolic syndrome. Now, what is cardio-renal metabolic syndrome? Let us concentrate on this picture. Beta cell dysfunction and insulin resistance, along with increased rash and sympathetic nervous system overactivity, natriuretic peptide related deficiency, and chronic inflammation leads to obesity, lipoglucotoxicity over liver, oxidative stress, and endothelial dysfunctions. This all leads to atherosclerosis, myocardial dysfunction, heart failure. So these are interrelated. Diabetes, fatty liver, liver dysfunction, glucotoxicity, lipoglucotoxicity, these all are interlinked. And this cardiovascular dysfunction leads to low cardiac output and vasoconstrictions. With that, sodium and hydrogen retention, RAS overactivations, uremic changes, these all leads to renal dysfunction. Renal dysfunctions leads to chronic inflammations, hepatic deficiency, uremic manifestations. So these all is interrelated. The slide will be there. You will find it in all the books, all the journals. Go through it. Try to understand the interrelations of these three organs: beta cell, heart, kidney. So the pinpoint treatment management is easier. So CKM or CRM syndrome is a systematic disorder linking cardiovascular, kidney and metabolic disorders, increasing prevalence, high morbidity and mortality. Our objective to understand the pathophysiology, diagnosis and management of CKM syndrome. I have already discussed the pathophysiology. Again, excessive dysfunctional adipose tissue in the liver, MSND. MSND, what is MSND? MSND is metabolic dysfunction-associated liver disease. What are the different kind of liver disease? Have you gone through the liver dysfunctions in your classes? Yes or no? Have you liver disease? Have you anyone given a lectures on liver disease? No. Okay. Liver disease, grossly we can divide. One is viral associated liver disease, that is viral hepatitis, that is acute. Some of them may lead to chronic liver disease. So there is a CLD. CLD is chronic liver disease. Another is ALD, that is alcohol related liver disease, alcoholic liver disease. And another is NAFLD, non-alcoholic fatty liver disease. When this fatty liver goes to steatohepatitis, then we call non-alcoholic steatohepatitis or NASH. Another is MAFLD, metabolic dysfunction associated liver disease. Basically, all are liver disease. Manifestations are same, but etiologically there are differences, and their outcome is also differences. So here we are talking about MFLD, that is metabolic dysfunction associated liver disease. You just minded the definition. There will be hypertension, dyslipidemia, metabolic syndrome, diabetes, excessive inflammations of the oxidative stress. They leads to dysfunctions of the kidney, and these inflammatory cytokines will damage the heart and kidney. These are the same I have already discussed. This is the repetitions. Now, interplay between cardiovascular, kidney and metabolic systems. What are the mechanisms? Basic mechanisms of CRM, that is insulin resistance and metabolic dysfunction. Next is inflammation and oxidative stress, that leads to neurohormonal activations and hemodynamic changes. So this diagram illustrating this interplay of mechanisms. These two diagrams are vital to understand what is CRM. So what are the risk factors? We have already discussed: diabetes, hypertension, obesity and dyslipidemia. Associated family history and lifestyle factors. We have discussed what are the lifestyle factors. How to diagnose it? Screening for risk factors and biomarkers. EGFR, albuminuria, etc. for kidney dysfunctions. And we have to stage the CKM syndrome. Stage 0, no risk factor. Sitting over here, young, how many of you have any risk factors? Family history, diabetes, hypertension, dyslipidemia, anybody? God. Family history, I am asking about you. Anyone? Have you screened yourself ever? You should. Because diabetes and metabolic dysfunction, liver disease are no longer a disease of the aged. It is now invading the younger adults also. And in newspaper, in your phone, you are repeatedly finding that young patients are having cardiac arrest in the gym. They are all healthy, acting, doing regular gym. Suddenly there is or a young people playing football suddenly had a cardiac arrest and a death. So these all are preventable. So you should screen yourself at least once a year to say whether there is any dysfunction. Stage is early warning signs. Early warning signs regarding diabetes, regarding hypertension, regarding renal functions. Stage 2, health risks start to show. You will find increase in the uric acid, increase in the triglyceride, increase in the fasting blood sugar. These are all the gradual coming up. Sequentially, these were all started. Increase in the weight. Next comes our heart and blood vessels problems begin, that is stage 3. And stage 4 is signs and symptoms of heart problems. So these are the things, these all come one by one. So management strategies, healthy lifestyle diet and physical activity. How many of you have taken breakfast today? How many have skipped breakfast? Particularly the ladies, they usually skip breakfast. Yes or no? Breakfast, you should take breakfast, otherwise the whole metabolic axis start dysfunctions from the very early period of time. Because our body by hypothalamus sense the need of energy and glucose metabolism early in the morning. We cannot change that. When you will go through the hormonal chapters, you will see that diurnal variations of the hormonal release is based on some predetermined factors which we cannot change. The release of insulin, there is two types of insulin release. One is in pulse and one is basal. Pulse is in the morning, in the afternoon and in the night. And basal is a continuous flow of insulin. So we cannot change this. So we have to make our diet according to our hormonal situations, particularly the insulin release. Say in the morning, the pulse insulin will release in the body at around 7, and that will pass through your urine if you unutilized if you have not taken food in the morning. So gradually the insulin response will be blunted and wasted. So you will take breakfast around 11, there will be no insulin to neutralize your food. Again, that food will remain unmetabolized in the body, in the blood. Again, you will take at lunch. At that time, you will have insulin. So that will be insufficient to metabolize your full metabolites in the blood. So there will be accumulations of the glucose or carbohydrates in the blood. So this way we start accumulating, and where it will be stored? In the liver first, and adipose tissues. So there will be fatty liver, fat generations. So please start your diet in the morning and plan. You did not take a huge amount, but sequence and time is very important. Weight management and smoking cessation. Smoking leads to release of some toxic metabolites in the body, and these are called ROS, reactive oxygen species. That is a very dangerous, and that damages liver and heart and kidney, everything. And that also causes some direct relations with cancer. Next is pharmacological intervention. We have to treat medications for hypertension, diabetes, dyslipidemia. We have SGLT2 inhibitors and GLP-1 agonist. The CKM syndrome is a complex condition requiring multidisciplinary management. Early detections and interventions can improve outcomes. Future research directions, precision medicines and targeted therapies. Now, I have just added this. What are the critical screening tests for diagnosing cardiovascular-kidney-metabolic syndrome? Please notice this particular screen that you should have or your family members should have annually. First, fasting blood glucose and HbA1c for diabetes screening, lipid profile for dyslipidemia screening, serum creatinine and eGFR. eGFR is estimated glomerular filtration rate. Urine albumin and creatinine ratio. Albumin creatinine ratio is the first manifestation. If you go through the changes in the kidney in renal failure, there will be first hyperfiltration, then there will be increased albumin excretions in the kidney, urine. At that time also creatinine will remain normal. Third stage, creatinine will go in rising. Gradually eGFR will come down and there will be ultimately that is called overt renal disease. That will be stage 5. Blood pressure measurement for hypertension screening. Anthropometric measurements is waist circumference and BMI. What is the formula of BMI? Height by beta square. Yes. What is the normal BMI? Yes. If it is 25, then it is obese, high BMI. And what is BMR? Other test, ECG or echocardiogram for cardiovascular assessment. These tests help identify risk factors and diagnosis CKM stages, stage 1 to 4. Some more information on the test interpretations. Fasting glucose more than 126 for diagnosis of diabetes. HbA1c for more than 6.5, diagnosis of diabetes. But 6.5 HbA1c does not require treatment, because our goal of achievement diabetic control is HbA1c 7. eGFR less than 60 is kidney dysfunction. Normally at your age it will be around 120. So at the age of 50 it is 60 is the cutoff. Urination more than 30 milligram per gram. Blood pressure 130/80. Waist circumference more than 40 inches for men and more than 35 inches women. That is central obesity. Waist hip ratio should be less than 1 or more than 1. Less than 1. Another index is there. You should know related to this. There is blood pressure difference, that is brachial and ankle blood pressure differences. So now what is the diagnosis criteria? Presence of more than 3 risk factors: obesity, hypertension, dyslipidemia, diabetes, kidney dysfunction, or presence of established cardiovascular disease. CKM syndrome staging: stage 0 no risk factor, stage 1 1 to 2 risk factor, stage 2 more than 3 risk factor, stage 3 established CVD or moderate kidney dysfunction, and stage 4 is advanced CVD or kidney failure. Management, again I am repeating: lifestyle change, healthy diet. DASH is related to hypertension and Mediterranean diet. Different kinds of diets are there. I am not going to details. Regular physical activity 150 minutes per week. Weight management, smoking cessation. Pharmacological interventions, antihypertensives. I have started with the first slide. You recollected that increase sympathetic nervous system activity and RAS activity. RAS is renin-angiotensin system. So this antihypertensive ACE inhibitors, ARB, are all against RAS, and beta blockers are against sympathetic nervous system. Statins for dyslipidemia, SGLT2 inhibitors, this is both for diabetes and kidney protection. These are newer drugs. SGLT2 inhibitors we are using for around 5 to 6 years. And this GLP-1 agonist is diabetes weight management. Before going to end this discussion, I will highlight two things. What is GLP-1? GLP-1 is glycogen glucose-like peptides in the intestine. It is released continuously in the gut. One interesting phenomenon is that last time I have discussed in the first discussions in diabetes, incretin effect. So someone has been given 100 gram of glucose intravenously and someone has been given 100 gram of glucose orally. Now we have measured the OGT, glucose testing, GT, not OGT, that is 30 minutes, 1 hour, 1.5 hours and 2 hours glucose testing. We'll see that the glucose level will go up in the oral glucose cases like this, and in the intravenous glucose level like this. So this gap is called incretin effect. When we are taking the glucose in the orally, this stimulates the GLP in addition to our normal insulin. In both cases, insulin is available in the blood, but in intestine, this GLP-1 are released. So they are metabolizing this factor which is absent in the intravenous effect. So this is incretin effect. Now GLP-1 has been deactivated by DPP-4 enzyme system. First came DPP-4 inhibitor. DPP-4 inhibitors are used for prolonging the effect of GLP-1. Later came intravenous GLP-1 agonist. Now this GLP-1 agonist has been hugely available in the market. As the patent of the international product has been off, so it is now available in a very cheaper versions. This is being used by obesity management drug. People are using over the counter and to reduce the weight. But warning signals are there. Everybody is being warned not to buy it from the market over the counter because this has got some severe side effects. Number one, the thing that I will take the injection, once weekly injections, and that will reduce my weight, I need not do to manage my diet, or I don't have to do exercise, is not the correct thing. You have to maintain your diet and you have to maintain your physical activity. Otherwise, the effect of this GLP-1 will be blunted. Number two, you have to use it lifelong. Whenever you stop it, you will revert back to the same situation. Number three, indiscriminate use causes renal dysfunction and pancreatitis. So, in a few days you will be acquainted with many persons will come, your friend will come, you will ask you how to use this. Please warn them. Only in the proper situation this should be used. This is a warning. Now the promisings are there that with reductions of the 10% of body weight, we can revert back fatty liver. So fatty fibrosis to fatty liver to normal liver with 10% of body weight reductions. It is documented. So our aim is to reduce the body weight by exercise and diet management. This will be our primary target. Repeatedly I am telling this. Without medicines, we have to try to revert back to our normal sequence.